like to welcome you all to this afternoon session, and it's my great pleasure to introduce our keynote speaker, Dr. Jennifer Zheng. She is the Surgeon-in-Chief and the James Utley Professor of Surgery at the Boston University School of Medicine. She's a highly regarded surgical oncologist and gastrointestinal surgeon, especially specialized in surgery of the upper GI tract. She graduated from the University of California, San Francisco for her medical degree and completed her master's degree at Harvard Chan School of Public Health. She completed a general surgery residency at the Massachusetts General Hospital and a research fellowship in molecular medicine at Harvard Medical School in Boston's Children's Hospital, followed by a clinical fellowship in surgical oncology at the University of Texas MD Anderson Cancer Institute. Upon completing her residency and fellowship, Dr. Zheng joined the faculty at the University of Massachusetts Medical School. In April 2006, she was named the first research scholar of the Pancreatic Cancer Alliance and later won a Howard Hughes Medical Institute Physician Scientist Early Career Award. The following year, she was the founding director of SOURCE, which stands for Surgical Outcome Analysis and Research, a research initiative to improve treatment strategies for surgical conditions and to develop tools to assess and reduce risk. She became later the first woman in Boston to lead a surgical unit in a medical school and teaching hospital when she was appointed chief and chair of surgery at Boston Medical Center. During 2019, Dr. Zheng was selected as director of the American Board of Surgery. As a result of her research, she was also named to various editorial boards of several journals, including the deputy editor of JAMA Surgery. In 2021, she was named president-elect of the Society of Surgery of the Alimentary Tract, and she's a founder and past president of the Society of Asian Academic Surgeons. Dr. Zheng has published more than 180 peer-reviewed journal articles on reducing surgical risk, cancer biomarkers, and on developing models for cancer treatment sequencing strategies with a particular focus on pancreatic cancer. She is an internationally acclaimed expert in evidence-based surgery for pancreatic cancer, and for this reason, she is the ideal expert for giving us the keynote lecture on pancreatic cancer surgery, evidence and future. Jennifer Zheng, the floor is yours.
Thank you, Helmut. That was wonderful. These are one of these things that you wish was recorded so your mother could actually see it, because my mother still asks me if the people will allow me to operate on them and all these kinds of questions that I'm sure you get as well. Let me see if I can figure this out. Button? No, I can't figure it. Green arrow. Aha. The big button. These are my disclosures. None of them have anything to do with what I am going to talk about today in particular, except I do have one disclosure, is I'm really actually bad at PowerPoint, and somehow the last time I gave a talk, it was for the initiation of the Peruvian chapter of the SSAT, and somehow I managed to, like a genius, embed the SSAT logo in all of my slides, and I can't figure out how to get it out despite help from the audience and all that kind of stuff. So, but I do want to say though that you should definitely all join the SSAT, because I'm the president-elect. Dr. Jean-Nicolas Votet is the president. We all look forward to his address in San Diego in less than a month or so, and it's a great organization. I'm just saying that's why it's embedded in all the slides, not that I'm really, really bad at PowerPoint. So we all know that I'm speaking to the audience in this room, and all of you are experts, and most of you could give this talk better than I could 10 times over, and I know people watching online as well. But I do see pancreatic cancer as a war. I think it's, and how do we win that particular war? All of us would be happy to be out of the pancreatic cancer business and operate on benign cysts and prevent cancer before it starts. So I divided it into a number of categories, only some of which we influence primarily as surgeons, but all of which we touch. And so there's a need for better targets. We need better understanding from basic and translational research. We need better tools, molecular tools, including all the various omics and the targeted drugs, which are now finally starting to make some sense in pancreatic cancer. And there's technical issues. There's the learning curve. I know there's a published on the learning curve in pancreatic surgery, pancreatectomy, and now minimally invasive pancreatectomy. And those are all meaningful questions. And then vascular resection and MIS. In our world, I'm not going to touch on this today in particular, but I will say a strong sense of mind in terms of how we win the war is that we still know that most pancreatic cancer patients that deserve resection and adjuvant therapy don't get it. There's a tremendous racial disparities in how we execute pancreatic cancer treatment, at least in the United States of America, and there may be analogous analogies in other countries and other places, but pancreatic resection and adjuvant therapy should be offered to all those who are eligible to receive it. And I think we can talk about that later, or we can talk about that in another subject, but I think that is incredibly important and something that we should remember. But finally, we need better strategies. We need neoadjuvant therapy, I will argue, and that's the main focus of this particular talk. And there's risk prediction and patient selection, who gets surgery, who doesn't, and who gets chemotherapy and who doesn't. And there's population-based efforts. So I'm going to focus most of this talk around neoadjuvant therapy. And I think that's the only real area of argument. I would argue that the only real area of argument for neoadjuvant therapy is resectable disease. This is a slide, and much of what I talk about is due to a pivotal 18 months of my life where I was a clinical fellow at MD Anderson Cancer Center, where I will say I really learned, like many of you, I don't know if Sai is still here, but many of us learned that actually it makes sense for all diseases, but potentially the area of argument is resectable disease. So this you can obviously see as expert pancreatic surgeons where the tumor is, where the SMV is, and the SMA, and that arrow pointing to the area, that magical area of clearance between the vessels and the tumor. So I will argue that pancreatic ductal adenocarcinoma is always metastatic, and it's just a question of whether it's macroscopic or it's a occult metastatic disease. A lot of my thinking around this it has been infused by MD PhD named Christine Icabuzzi-O'Donoghue, who was actually a Boston University School of Medicine MD PhD student, and then obviously went to a started career at Hopkins and now right around the corner here in New York. So to grossly oversimplify her papers, she and her group were able to demonstrate different clones from their rapid autopsies from the pancreas, from various sites of metastasis, including peritoneum and liver, lung, et cetera. And in so doing, they did complex mathematical modeling that it would require someone who's taken my son's current math classes in high school that I can't actually really understand myself, but to be able to model the various clones, at which point the progenitor cell becomes a tumor cell, that then becomes a metastatic clone. And in their modeling, they basically identified that pancreatic cancer has been developing for the better part of a decade before it's identified in a potentially resectable, macroscopically non-metastatic location. And their paper in Cell early demonstrated that, or proposed the argument that there's aggressive systemic therapy should be given early, after the diagnosis, and not after we perceive macroscopic metastatic disease. So I'll move from there to say that we also know that there is a U.S. failure to treat. Carl Villamoria, who was trained at MD Anderson, Northwestern, and MD Anderson is now a professor at Northwestern, demonstrated when he was a research fellow at the American College of Surgeons doing the NCDB before there was the National Cancer Database, that there was a U.S. national failure to operate, and he published it in Dr. Lilimo's little journal, The Annals of Surgery. Gulnara Kasimova is a a clinical surgical oncology fellow at the Ohio State University. I know that Tim Pollock, if he's was here earlier for sure, and he would want to make sure that I said the Ohio State University for surgical oncology, and under Alan Sung, who is now moving to the University of Virginia as chair. But Gulnara Kasimova was a categorical resident at Dartmouth and was a research fellow with me for 2 years. And she came up with this hypothesis herself. So this is what we do at SOAR, which you've heard about as our research group, Surgical Outcomes Analysis and Research, that is now based at BU and BMC. We take our research fellows, and they come from all over. We are lucky enough to have research fellows from Dartmouth, from Yale, where someone's coming from MGH, and obviously from Boston Medical Center, and BU, and BIDMC, many of who've presented today or previous days on virtual posters and orals. But she came up with this proposal herself. I did not give her this research project. I did not give her the idea. When somebody starts with us, we may put them on a project. I may have an idea. Dr. Tevye Sachs or other PIs may have an idea. The senior research residents may involve them on projects. But then it's kind of like Star Wars and the Sith. There's always a junior and a senior, or an apprentice and a master. And so by the time Gulnara was in her second year in the lab, she came up with this research hypothesis and the database and how to do it herself. And this was presented at the IHPBA in Brazil. So this is where, and it was published in Surgery. So, but what she demonstrated, this is the main slide that I think is important, is that in the United States, at least, we fail to treat pancreatic cancer patients systemically. And you can see here that only a small majority of patients at stage 1 disease actually get resection. A lower percentage of patients get resection at stage 2 disease, and a trivial minority of patients obviously get resection at stage 3, none at stage 4, but many patients at stage 3 and 4 do not get any treatment at all. No adjuvant therapy, no systemic chemo, obviously no surgery. So this is updated from 8 years before from Carl Billamorio's work. And so why do we not give adjuvant therapy in resected patients? There are a number of reasons. Some are treatment related, and there's surgical complications, as you know. Of course, we're all perfect and we have no complications, but those people that do have complications, their patients can have a delayed recovery and not get adjuvant therapy in a timely fashion. The largest window that we could accept adjuvant therapy would be 3 months, but honestly, it's probably 6 weeks, the time at which we should be hoping our patients would be getting adjuvant therapy. Jim Carroll, who was a research fellow with me from UMass, is now attending at UMass, but he demonstrated in JOGS that the inpatient mortality was 8.1% nationally after pancreatectomy for cancer. But readmissions is higher. So readmissions was 16% within 30 days. Tara Kent has done some important work on readmissions. I know she's in another room, but I just spoke with her. And 53% at 1 year, also in the Journal of Gastrointestinal Surgery. Some of them are patient-related. Why do patients not get adjuvant therapy? It's age, preoperative performance status, medical comorbidities. Patients may actually choose not to have surgery. Refusal is a word I've stopped using in research. Now, I think patients choose things, and whether or not patients are non-compliant or they refuse, I think especially the research that we're doing around the era of disparities in health equity demonstrates that we probably shouldn't say things like refuse or declines, but figure out the choices that patients make around how we're presenting their choices to them. But sometimes it's disease-related. The patient progresses. So this is Jim's work again, Jim Carroll's work again, but I had this hypothesis at some point when I was young. I was just a junior attending. I was probably still on that Howard Hughes Early Career Award that you alluded to. I thought that there would be some tremendous perioperative risks that we know after pancreatectomy. So the patient has a fistula and has a terrible, pseudoaneurysm and dies, et cetera, or dies of sepsis. And then there would be this golden period where they're done with their operation and then they are fine and they're just recovering and they're having chemo or whatever. And then they would die of disease progression, because we know most people die of disease progression. But actually, Jim found that was not the case. There's a constant mortality risk. Once you get out of the postoperative period, obviously where there is a significant risk, it's actually constant over time. So there is no golden window for a pancreas, for the average pancreas patient. So many of you are at elite single center cancer centers where cancer is the only thing that you do. There are you'll see my biases, but there are places where there's, I'm joking a little bit, but there's experts of the left breast and there's experts of the right breast. And so that's, people have said, when people get up here and talk about neoadjuvant therapy, well, that's okay at pick your elite place that only does neoadjuvant therapy, but it actually doesn't work in my real world. In Boston, you can't swing a dead cat without hitting an expert pancreas surgeon or being at a quote-unquote high-volume center. So what happens if you offer this patient neoadjuvant therapy and they go across town or just 20 miles out of town and find somebody who's like, well, yeah, I'll operate because my chairman says that I need to make this many RVUs. And I mean, not that you're actually thinking that, but you want to do an operation. And when you're a surgeon, you want to operate. You know you can cure people with operations, so why wouldn't you want to operate? Why wouldn't you want to give person that chance? So in the elite cancer, with that big caveat, in the elite cancer center experience, that a neoadjuvant strategy has a higher rate of multimodality completion. And this is Qingwei Tseng, who's probably here, but he's no relation to me whatsoever, despite the fact that he misspells his name Tzeng. But he also found that the multimodality completion improved survival compared to others. So again, I would say that resectable pancreatic adenocarcinoma is about equal to occult micrometastatic disease. And this is Tim Pollack and Chris Wolfgang, again, who works down the street, at a debate for the SSAT last year. And I debated Chris, and I think anybody who was there will agree that I won. But systemic therapy, it's a systemic therapy for systemic disease. More than 75% of patients who are diagnosed with locally advanced disease or metastases, but more than 95% of patients have metastases at diagnosis or will develop metastases during their follow-up. This is a patient shared with permission of my chief of surgical oncology, Dr. Tevye Sachs, who did his residency at Beth Israel Deaconess Hospital under Dr. Tara Kent and Mark Callery, and then him pictured with some of his mentors along the way, Dr. Cameron and Mrs. Cameron, as well as Dr. Warshaw, who knew him as he was growing up. But this is a patient of his. We've all had this patient. So he had a patient he did a Whipple on, and 3 months later, hadn't even had adjuvant therapy yet, the patient blossoms with metastatic disease in the liver. That is not a patient that any of us would do any favors by operating on. So what are the barriers to a neoadjuvant strategy for pancreatic cancer? Well, there's clinician acceptance, as I mentioned. You need surgeon buy-in for this. And I admire my colleagues in the Netherlands and other places where they can actually randomize patients and actually have patients comply, again, to use another word that I don't like very much, with randomized treatment. And I know Mark Besselink at least was here earlier. I would welcome any comments on how we can actually herd the cats of surgeons and medical oncologists and patients more effectively into a randomized clinical trial in places like the United States. But short of that, I think we, again, like to do what we're good at, and we know what to do. And if a patient gets sent to a surgeon, it is often, if they look resectable, it's hard not to offer that patient resection. So at least in the US, no randomized controlled study has been done. And I would argue that there's no randomized controlled study will be done with a long course of neoadjuvant therapy, and then again, all credit to the study which is being done now. I would argue that isn't necessarily the longest course of neoadjuvant therapy, but that will actually determine whether or not upfront surgery or neoadjuvant strategies are appropriate in resectable pancreatic cancer. We'll see. I mean, maybe the accrual will be wonderful. It is very hard, in my estimation, even at top academic centers, to accrue people in a randomized study to surgery or neoadjuvant unless it's really presented as gospel. So this is a study by Susanna de Hus, who's going to be a resident in general surgery at Beth Israel Deaconess Medical Center starting, I think, July 1 or June 23rd of this year. So congratulations to Dr. Kent for recruiting a wonderful, wonderful person who many of you know, but if you don't know her, she will be a force to be, already is really, but a force to be reckoned with in the pancreatic cancer field. She's experienced in both basic science research, translational, and now outcomes research. But she did this decision analysis that was using a Markov model, which basically demonstrated that neoadjuvant therapy offered substantial benefit in terms of survival, and when you put quality of life in, it offered an increased benefit. This is a paper from another institution down the street, Memorial Sloan Kettering, which has been much looked at. It came out about the same time as those papers by Christina Acapuzzi-O'Donoghue that I alluded to, but it basically showed, using the impressive Memorial Sloan Kettering databases, the survival curves of pancreatic cancer adenocarcinoma patients over time. And at the time when the study was done, looking at the 2000s, which are in green here, there was no change in the curve. I will say this is immediately after the failure of all the GEM doublet studies, and now with FOLFIRINOX and with Gem-Abraxane and some glimmerings into targeted therapy that works in pancreatic ductal, certain subtypes of pancreatic ductal, there's a little bit more light for the adjuvant therapy. But again, these curves had not changed for decades and need to change. So people often think of the centers that I adore and worship as the standalone major cancer centers as a form of Disney. When you talk about a center like mine, which is Boston Medical Center, this is MD Anderson Cancer Center, of course, but a center like mine, Boston Medical Center, or any place that has a lot of different concerns and doesn't have necessarily a unifying cancer policy, how do we get neoadjuvant therapy to be accepted for resectable pancreas cancer? This is BMC, and I hope you'll come visit if you haven't already, but I consider it very much the real world. So neoadjuvant in real life, there's upfront surgeries on the left, you'll see neoadjuvant is on the right. Upfront surgery is okay, but I still would argue it's not the preferred treatment for most. In patients that are healthy or young and that are likely to withstand surgery okay and not have a complication, but you all know that we have patients that are great and still have a complication. So all those prediction rules that I spent my early career doing, which I didn't bore you with today, they're not perfect. Dr. Vollmer used to get up and say to me when I was presenting my early prediction rules, like, how can you predict how come none of these rules are 100%? How come none of your area under the curve is perfect? You can't. And I don't know if Dr. Pitt is here at this particular meeting, but all the NISQIP calculators, they're not perfect. So even if you think the person's likely to withstand surgery, they may not. No definitive tissue diagnosis. Now, obviously, in most centers, that's going to be a non-starter to not have a tissue diagnosis and give chemotherapy. But in general, you can get a tissue diagnosis. You just have to try harder. Someone who's unstentable and has jaundice, someone who's unstentable and has biliary obstruction, that potentially is room for advocating upfront surgery, at least to bypass them. And then potentially patient preference. Obviously, we're not going to boss our patients around. Our job is to tell them what we recommend and give them the evidence, and then we want to support any of their decisions that they make that are reasonable. And social determinants of health. So again, Boston Medical Center is the real world. My patient population at Boston Medical Center is incredibly diverse from all different diverse economic standpoints. I have people that fly to see me or one of my partners for something else from all over the world. And then I have people that are from the Mass and Cass encampment, which if anyone from Boston knows, is this homeless encampment down the street. And so potentially somebody who's homeless or somebody who is not responsible or doesn't have the wherewithal, and we can't give them the wherewithal to make it to their neoadjuvant appointments, would benefit from upfront resection. But what favors neoadjuvant? Somebody who has kind of marginal performance status, we would favor neoadjuvant. Of course, the med-oncs are going to tell us, well, they're not going to tolerate GEM, but if they're not going to tolerate GEM, they're not going to tolerate surgery. So as somebody wise once said, there are borderline resectable tumors, and there's also borderline resectable patients. And so I think using a neoadjuvant test for patients is actually not a bad thing to see if they can tolerate their FOLFIRINOX or even their GEM. That is actually a little bit of a test. There's also a test that they're actually going to potentially have the wherewithal, mental and familial and everything, to be able to tolerate what's going to happen to them after a big surgical resection. And you can always stop chemo. You can't really stop an operation after you've already done it. Biopsy-proven pancreatic cancer obviously favors neoadjuvant, and if there's vascular involvement or borderline resectable disease, we all, I think, pretty much have gone on board that in general, if you're planning on doing a vascular resection or if it's a borderline tumor or both, depending on how Katzian you want to be in your definitions, it's time for neoadjuvant therapy. And then again, we talked about the social determinants of health, which you now know impact impact our patient outcomes tremendously. But overall, for both of these strategies, for any strategy regarding pancreatic adenocarcinoma, I would strongly argue that a multidisciplinary team and a patient-centered approach is important. So not just one driver of the multi-D team, not that I'm the surgeon and I know what's right and I'm just going to ask other one and get their blessing, or vice versa. The med-onc has an opinion and they just get a surgeon maybe involved at the last minute to ask a question. It really needs to be a true partnership. So this is a patient shared with obvious permission. So I'm old enough now that I know people that have been around for a long time with pancreatic adenocarcinoma. So this is a guy who was diagnosed with pancreatic cancer, painless jaundice, went and had an operation at a major hospital in Boston, and was found to have disease involving the hepatic artery, and right hepatic artery. He had attempted resection, aborted, and had it open, double bypass, biliary bypass, and a gastric bypass. And then he was told, this is what he told me, but he was told that he had 6 to 12 months to live, and was told to go, if he wanted to fight, he could get some palliative chemotherapy. He's a smart guy, and he did his own research, and he falls in a demographic that is able to travel and able to pay for stuff and able to take time off of work, which are all things, again, I'm not going to talk about today, but really do matter. And he found actually a center in Texas that told him he could get more than palliative chemotherapy. So he went, and he saw this guy who has now cleaning his boat, but it's Doug Evans if you don't recognize him. He found him in Texas, and despite their lifelong antipathy about some things, they bonded over other things, and Doug recommended neoadjuvant treatment. He ended up having neoadjuvant treatment back at home in the Boston area with both chemo and radiation, and he came back, and when I was a fellow, he was resected at MD Anderson with a vascular reconstruction of his right hepatic artery. And he's now 19 years out. I get to follow him. That's my job, is to follow all of Doug Evans' patients that live in the Massachusetts area. So he and his wife, who you see here, they have truly won the war on pancreatic cancer. I think now he says he just needs to worry about things like getting old, like his knees, his old football injuries afflicting him, and all that kind of stuff. So I think it is possible to win the war on pancreatic cancer, but we have to be really careful and think about which tools you want to apply when. And that's my last slide. Well, thank you very much for the floor, and I appreciate you all listening to me.
Thank you for your excellent presentation. Are there questions? We have time, 2 minutes time for the short discussion. Jennifer, what is the role of tumor boards in the United States? Because from your presentation, I got the impression when you move in a surgical door, the surgeon is evaluating the patient and is finally deciding what is happening with him. In Europe, if the patient comes before the decision is made what is done with the patient, we discuss these patients in an interdisciplinary tumor board where gastroenterologists, radiologists, surgeons, oncologists are discussing what is the best treatment strategy.
Thank you. I think it varies institution to institution, because I think to have a Commission on Cancer accredited program, you have to have a multidisciplinary tumor board, but we all know there are tumor boards in which there's one dominant or a service that is dominant, and often that if the surgeons are very dominant people, and I suspect that there are others which are not. I just maybe happen to be I'm a pancreas surgeon, somewhere around a lot of strong-minded people. I think it's not a requirement that every patient gets presented in a tumor board in the United States, though. It's that some do, and individual doctors need to decide to put their patients on the tumor board. There may be some institutions in which all patients are discussed at a multidisciplinary tumor board, but to be honest, we see so many patients. At my center, which is a medium-sized center, we see hundreds of patients with pancreatic cancer a year, and to present all of them in our multidisciplinary tumor board would be impossible for time to actually have a good discussion. So I think it's not a mandate that all are presented. It is a mandate that for Commission on Cancer accredited, ACS accredited hospitals, that there is a tumor board.
Thank you. If there are no more questions, thank you for your presentation.
Thank you. Let's see.
Now, good afternoon. Tom Gallagher from Dublin. I'm delighted to introduce our next speaker, Dr. Alice Way. Alice is a surgical oncologist here in Memorial Sloan Kettering in New York and is an associate professor in the Weill Cornell School of Medicine. She's co-director of the surgical initiatives in the Rubenstein Center for Pancreatic Cancer Research. Dr. Way graduated from McGill in 1995 and undertook her residency and subsequent HPP fellowship in Toronto.